Welcome to Chronic Things. In this podcast, I talk to Geraldine, an Australian dietitian who focuses on running a private practice designed to help patients with IBS and food intolerances. We cover what IBS is, the different tests which may be used, commonalities and differences between patients, other health issues which may present with IBS, and we also talk about food chemicals and FODMAPs. Talking to Geraldine was really fun, and I hope you enjoy the podcast as well.
Picture in person. I wonder, could you just give me a sort of, what do you say, a sort of brief introduction about yourself, about your sort of background and what it is you do?
Yeah, so my name is Geraldine Perez. I'm an Australian dietitian based in Wollongong, which is about 90 minutes south of Sydney. And I run a private practice that is almost solely focused on managing patients who have IBS and food intolerances. So I've actually also been on maternity leave. So I'm just coming back on in the space. And I've had another dietitian who's been working with me as well. Her name's Kiara. She's been amazing. So we're a tight-knit little team working with patients with this condition.
Okay. And so is mainly IBS and sort of gut health issues that you actually focus on primarily?
Yes, that's right.
Okay. So I think one of the obvious questions that I want to ask you first really is sort of what is IBS? And also, I wonder if you could tell me sort of what other gut conditions you actually focus on as well. I'm kind of curious.
Yeah, so majority of our patients have been diagnosed or on their way to being diagnosed with IBS. And IBS, or irritable bowel syndrome, is essentially a condition of exclusion. And I'll explain that to you in just a moment. But essentially, it's characterized by a number of digestive symptoms that can really impact on someone's quality of life. So things like bloating, excessive wind, stomach pain, and altered bowel motion. So some people can get quite a lot of diarrhea. Some people can have constipation. Some people actually go both ways. And the severity and the frequency of the symptoms are also changing all the time, which can be really frustrating for patients too. Okay. When I was talking about exclusion, would you like me to run through what I mean by that, with the condition being...
The condition of exclusion, do you say?
Yeah.
Yeah.
So when someone's diagnosed with IBS, essentially what usually happens is a doctor runs a series of tests. So that might be things like blood tests, stool tests, breath tests perhaps, and what we're looking at here is testing for conditions that are not IBS. And so essentially when everything comes back as being normal, it looks like nothing's wrong, but these patients have real symptoms. And that's kind of when IBS is usually diagnosed.
Okay. So you're excluding everything else and then diagnosing IBS. Is that the idea?
Yeah, essentially. And it's really frustrating for patients and doctors alike in that way as well, because everything does look normal and comes up as being normal, but these patients are really suffering with their symptoms. So doctors have nothing essentially to treat because it looks normal, and likewise patients are really frustrated because everything looks normal, so it almost feels like they're making it up sometimes when obviously they're absolutely not.
Yeah. I mean, I can relate. I was actually diagnosed with IBS some years ago, and I went through this sort of same process that you described. So blood tests, stool tests, endoscopies as well. So sort of camera down the throat.
Yes, of course.
Take a biopsy, and everything, of course, comes back normal, and then you wonder actually what's going on. And so they ended up dying. IBS, I think, was the final diagnosis.
Yeah.
I think what in your experience sort of seems to actually cause IBS?
So IBS is not entirely understood, but what science is currently thinking in terms of what's causing the condition is a number of factors that might be intertwined. So, for example, one of those things could be IBS type symptoms following an infection. So sometimes this is termed post-infectious IBS. So a patient might have a bout of gastro, for example, and it's an extended period, and then their gut isn't the same after that. So they present with these IBS type symptoms. Other sort of causes for IBS might be things like someone who has more of a very sensitive gut. Their receptors are highly sensitive and reactive, more so than someone who's not, and this is called visceral hypersensitivity. Some other causes that can sort of bring on or exacerbate IBS are things like stress, as well as multiple antibiotic use, which I suppose then would be changing the gut bacteria and the way that they behave and the population within the gut as well.
Okay. Is it? I'm kind of, so I wonder, in the patients that you see, is there any sort of one cause that appears to be more common than any other cause, I suppose?
No, it seems to be very much a mixed bag. So I have some people who have had gut issues all their life, and I have people who it feels like they've woken up and started to get these gut symptoms. You know, for example, they might have that gastro bout, or they might have something very stressful in their life that's happened, whether that be an emotional stress or a physical stress, which has then triggered off IBS type symptoms, like moving house, or a breakdown of relationships, or an operation, or childbirth. I see all of these sort of factors that seemingly trigger off their IBS symptoms, and then the symptoms never go away. So they're looking to find ways to manage them.
Okay. I think, do you tend to find that one symptom tends to be the single most inconvenient symptom for the patient? So I'll give you an example. I think some people that I've talked to, they said they can deal with all the other symptoms, but the one symptom they would like to get rid of is the bloating, for example. It's one sort of symptom that you come across with patients where they say, actually, even if I had to live with IBS for the rest of my life, I would just like to get rid of, this, whether it's the cramping or the bloating or something else.
Yeah. So again, it is a bit of a mixed bag with what symptom is bothering them the most. However, I think the standout for me personally, and what I see, is when the patient is getting a lot of stomach pain, which makes it quite debilitating, and it stops them from being able to get out and do what they need to do, like socialize or go to work, go to school, that sort of thing. But I will say that all of the other symptoms as well definitely have a really significant impact on, or can have a really significant impact on, their quality of life as well. They're always looking, their life basically revolves around the toilet and how their gut is going to behave in situations because of all of its unpredictability.
Okay, I think in terms of the gut pain, for example, because two questions sort of pop into my head. The first is, does everyone present with gut pain? The second one is sort of, is it always in the same place that you've seen? Is the gut pain always, for example, in the lower abdomen, or is it always in the upper abdomen, or maybe sort of to the sides at all?
No, not everybody presents with stomach pain or stomach cramping. Some people do present with just bloating that they would like to manage, for example. I guess clinically we call this more functional bloating rather than IBS per se. But going back to the pain, clinically speaking, it is lower abdominal pain that people will experience with IBS. However, I do see people who have pain in all different areas of their stomach. Some people complain of upper abdo pain, and we don't really know why, or on the sides a little bit more on one side than the other side and that sort of thing. I guess at the end of the day, when it does come to pain, it comes down to, or one of the things that it comes down to is how hypersensitive that patient is in that area. And that's where that visceral hypersensitivity comes into play, where their receptors are just highly reactive, highly aware of things or stimuli around them that can irritate them and trigger off this pain feeling.
Okay. And I would guess that the severity of the pain differs across patients. So I would imagine that some patients, the pain it's okay, it's a nuisance, it's annoying, but they can deal with it, while others, actually the pain can be quite debilitating. It causes them to it's quite disabling in that sense. Would that be correct?
Yes, absolutely. We get people, of all levels of pain that come into the clinic for sure.
Okay. Also, so I think you mentioned obviously that IBS tends to affect sort of people's everyday life, that they find themselves sort of in social situations kind of having to use the toilet more frequently than they would like to. Have you found I correct me if I'm wrong, but I believe some people, when they have IBS, they'll have IBS sort of C, which is constipation, and or someone can have IBS D, which is essentially more diarrhea-like. Have you sort of seen anything that would suggest to you that one is more common than the other? Is one, for example, is one easier to kind of live with, or have you seen anything like that?
Yeah, so again, I think it is quite a mixed bag that we see with, there's no predominant subtype of IBS that comes into the clinic. We do get both ends of the spectrum, diarrhea, constipation. We also get IBS-M, which is the mixed type of IBS, where they alternate between the two types of bowel motions. And I can't remember the second part of that question. I'm sorry. If you remember.
Yeah. So it was just which one out of IBS sort of C and D, would you say, which one more severely affects?
Has the biggest impact?
Yes. Yeah.
I think they both have their challenges. I don't think you can say one is, I guess, more debilitating than the other. Because, for example, when we're looking at a diarrhea predominant subtype, that person may be looking to go to the toilet multiple times a day, and so their days are focused around where the toilet is, if they're going to have an accident and so forth, and that can lead them to not wanting to leave the house. On the flip side, when someone has the constipation predominant subtype, their challenge is actually going, and they can go days, weeks without going at all, which can cause a lot of bloating as a side effect as well. And they may need to take quite a lot of supplements or medications in the end to try and empty themselves out, which can also be a challenge too, and then their cycle starts again. So that can be a bit of a challenge too. I wouldn't say that there's one that's harder than the other, I think.
And I wonder. I wonder if so one I guess you could say one question that I've wanted to ask, and I've never sort of had the opportunity is so I've certainly heard of some people, having IBS for say 12, 15 years, something like that. And I've noticed, for example, in other diseases, if you take migraine, for example, some people find that over time, for example, if you have migraine over time, it can get slightly better. In other words, the pain can sort of decrease somewhat. Not obviously in every case, but at least in some cases. I wonder, have you noticed that for IBS? So, for example, someone sort of comes into the clinic and they said, "Oh yeah, I've had IBS for say 10 years." And initially, when it started, it was horrible, and I was in so much pain. But now, the pain's slightly better. I can sort of live with it more. Or would it just be a case that they've kind of just learned to live with it, and it hasn't really got any better over time?
Yeah. The only consistent thing about IBS is that it's very inconsistent. And so over time, it can actually get better or worse. And there are a number of factors that can sort of impact or influence whether it can get better or worse. And some of those things are things that person will do directly, and some of those things might happen by chance in their lives. And there are other things that can happen that can improve IBS, and we kind of don't know about them yet. We don't know why. But I guess if we're looking for some ways that improve IBS, over time, they include things like lowering stress levels. So, for example, I've had a patient when I was working more recently who had really, really significant IBS. Came to me obviously to find out what food triggers they had, but we also found that a really big impact on their stress was their work. So they actually changed jobs, and their IBS symptoms were a lot better. So that's an example of something that they can control. However, there are some instances where IBS does seem to get better over time, and we kind of don't really know why, but we're kind of thankful that it does. But when people come to me, we're looking for food triggers anyway. I just wanted to also mention with migraine, Jamie, I'm not too sure if you're aware, and might be slightly off topic, apologies if it is. There are quite a number of people who present with IBS symptoms as well as migraine as well. And there are food triggers that are associated with both of those things that are intertwined.
Yes, yeah. In fact, that was actually one of the sort of questions I wanted to ask you.
Yeah.
Are there any other diseases, any other sort of comorbidities any other health problems that seem to kind of tag along with IBS sort of for the ride, so to speak?
Yeah. Okay, so when we're specifically looking at digestive symptoms, IBS symptoms are quite common in people who also have other diagnosed conditions such as endometriosis, inflammatory bowel disease, so that includes colitis, ulcerative colitis and Crohn's disease, celiac disease, SIBO, diverticulitis. All of these conditions can have really similar conditions to IBS, and someone can also have those conditions as well as IBS. In addition to that, people who have IBS may also present with symptoms that don't necessarily have a specific diagnosis, but have symptoms that are related. So that's where the migraine type of symptoms come in. So if we split it up though, the way that I like to sort of manage this in my mind is essentially we've got gut symptoms with IBS, but we've also got a second system of the body that is interrelated, which is the nervous system. So we see things like headaches and migraines, and Then we've also got skin conditions. So we might see someone with IBS as well as eczema or skin rashes or swelling. And then we've got the fourth system of the body, which is the airways or the respiratory system. So we might see someone who also has symptoms like hay fever type of symptoms or asthma type symptoms. And not all the time, but sometimes they can actually be related to, for example, foods that they're eating.
Okay, that's interesting. So patients can kind of walk into sort of talk to you, and they can have maybe sort of two or three other sort of diseases or health issues that actually can either make their life more painful, or do you ever find that those other kind of health conditions make the IBS worse that you've seen, just maybe compared to other patients who don't have that condition, I wonder?
So I don't think it makes their IBS specifically worse. It does make their life more challenging with more symptoms that, that they're trying to manage. They might not even realize that those other non-gut symptoms are related. I wouldn't say specifically it makes their IBS worse, but in saying that, when we're looking at food triggers, I do tend to find that these patients are more of the complex type of patients as well.
Okay. And then, so you mentioned sort of food triggers. Are there any foods actually that really do trigger IBS for a lot of people? Any sort of specific foods?
There are many. So I guess I'll highlight the really common ones. So you may have heard of things like FODMAPs. That's quite a common food trigger that we know about these days. It's quite a new discovery. About 15 years ago, FODMAPs were discovered. And FODMAPs are types of carbohydrates that are poorly fermented in the gut, poorly absorbed, and they're fermented in the gut, and they trigger off symptoms. And they include food sources like onion, garlic, apples, pears, a bunch of other things. So really healthy, generally healthy foods that are not healthy per se for someone who has IBS. In addition to that, we've also got something less commonly known. Actually, I might hold that thought. Some other common ones might be dairy or gluten, or things within dairy or gluten type of products, like lactose, for example, in dairy products, or fructans, which is a type of FODMAP actually found in gluten or wheat type products. There is another really common trigger that we probably see more often than not, because of the people who come and see us, and that's food chemicals. So I'm not sure if that's something that you've heard of before or are familiar with at all.
Food chemicals. So
may not be what you think it to be.
No. So the thing that comes into my mind is potentially, and this is a guess, but sort of pesticides and things that are sprayed onto food. I'm not sure if that's correct, or I'm missing.
That's okay. Yeah, close. I guess there's two types of food chemicals that we're looking at. One of them is a natural type of food chemical. I'll come back to that one. The other one is a man-made type of food chemical. So we're not specifically talking about pesticides here. We're talking more about man-made additives that are added to food. So things like preservatives, colors, flavors. There are a number of those that are more well known to trigger off IBS, as well as the other symptoms like migraines and skin rashes and so forth. And then we've got this other collection of food chemicals that are naturally sourced, and there's sort of three categories within the natural source. They're called salicylates, amines or histamines, and glutamates. I'm not sure if you've heard of them, but essentially they're found in a wide range of otherwise healthy normal foods as well, but can be a bit of a trigger for people with IBS. So there's a bit of crossover of food chemicals and FODMAPs when it comes to IBS as well. So there's a whole range of foods that can potentially trigger off someone and their symptoms.
Okay, so if I understand you correctly, it's so man-made chemicals such as additives. I think you said food colorings. I don't know if like things like emulsifiers would be one or not. And then you have the sort of more natural things like histamines that can be found, I think, in aged meat might be an example of a source of histamines, if I remember.
Yeah, that's right. Yeah. Emulsifiers I don't find to be too much of an issue, but yeah, all of the other examples that you did provide are examples of really common triggers when it comes to food additives.
Okay. And you have you sort of seen, so when you talk to patients, do you suggest sort of removing all of these from the diet, or is there like, or do you say to them, you know, this is the one thing out of this list that you really don't want to eat or consume?
Yeah. It really depends on the patient. There's a number of factors that we need to consider to determine whether we do, I guess you call it a full medical elimination diet, or whether we start with more of a simplified and targeted approach. So what I mean by that is if someone comes to me with, X symptoms, and they have no idea what foods trigger them off, based on a number of things like their medical history, their actual symptoms, family history, what they're currently eating, things like that, then we might do a full elimination diet to strip the diet back just to settle down the symptoms. And if that does settle down the symptoms, then we know that one of those triggers that we've tried to target is a problem, and then we systematically bring them back in to figure out which ones it is, because we don't want them staying on that stricter elimination diet forever. On the flip side, when we're looking at more of a simplified targeted approach, someone might come to me and they might go, hey, I know that bread really sets me off. This is a really simple example, but I know that bread really sets me off. All right, cool, no worries. Let's have a look at what you're eating. And they might still be having some crackers, maybe some pasta now and then. And what this then tells me is that the food trigger that's found within bread, so in this example, it might be fructans found in wheat is what it's called. It's a type of FODMAP. They're still consuming the same food trigger, but just in other foods. And so that's where we might do more of a target approach. And I'll say, hey, let's remove the fructans in wheat for a couple of weeks and see how that goes. And we won't touch the other food triggers. So that might actually be enough to settle your symptoms down completely or to a level that you're happy with. And so that's how we do more of a simple approach. I guess the other thing is it also depends on, how ready that patient is to do something more complex, or if they prefer to do more of a simple, I call it a top-down approach, so taking off a little bit at a time, whereas stripping it right back, I call that more of a bottom-up approach. So depends on what they would like to do as well as what our findings are.
Okay. Sorry, we've got about 8 minutes. If you want to continue talking after that, I can sort of reboot the Zoom call.
Happy to, if need be. It's all good.
I think so. You mentioned FODMAPs. So if you have a patient and say they're avoiding sort of FODMAPs or food high in FODMAPs, is it about completely eliminating FODMAPs, or will there be certain foods that they can eat in maybe a small quantity and then other foods they can eat more of? So in other words, are there foods that might contain very, very small amounts of FODMAPs unless you eat them in large quantities?
Yeah, so the answer for that lies in the name itself. So it is actually a low FODMAP diet rather than a no FODMAP diet. So there are specific cutoffs that when FODMAP foods are eaten in certain amounts, do not, for the majority of people, do not trigger off their symptoms. And so they just need to make sure that they're eating below that amount. Likewise, though, just because someone needs to follow a low FODMAP diet as a temporary diet to see if that settles down their symptoms, we'll find that majority of the time, there's only a few of these FODMAP groups that actually trigger off their symptoms. So they're not going to be avoiding all FODMAPs forever. In fact, I would encourage them not to be, because FODMAPs are actually really good food or fuel for the healthy bacteria that live in our gut as well.
Okay. So in order to maintain a sort of healthy gut, you actually need the FODMAPs as well for the bacteria to sort of feed on, the good bacteria.
Yeah, so it's a bit of a balancing act, because FODMAPs are great for your gut and your gut bacteria, and they have important roles in the body to keep you nice and healthy. But at the same time, you don't want to be triggering your own symptoms. So it's bringing your own FODMAPs, or if FODMAPs are an issue for you, bringing them down only to a level that manages your symptoms and not being overly restrictive if you don't need to be.
Okay. And so I suppose the idea then for people is to kind of lower the FODMAP but not eliminate it, while being sort of being conscious of the fact that they may have to avoid, as you previously mentioned, sort of certain chemicals, sort of additives and histamines and so on and so forth. Does that sound about right?
It depends on which approach we're taking with the patient. So, sometimes we might just try a straight low FODMAP diet, which has several stages. It might be helpful if I run through that briefly in a moment. Some more complex patients, in the way that they present, we might do more of a combination approach where some FODMAPs and some food chemicals are limited in the diet at the same time. But we only do that when necessary. We try and only restrict to a level that is likely to be needed to get results. So if we go back to the straight low FODMAP diet, just going through that really briefly, the low FODMAP diet has 3 stages. So again, you can do a targeted approach where you're only reducing 1 or 2 FODMAPs depending on the patient. But if we're talking about a straight low FODMAP diet, the initial stage is full elimination. So we're reducing all of the FODMAP groups down, and we're doing that for 2 to 4 weeks, generally speaking. And if the symptoms come back, they don't come back, we want them to go away. If the symptoms resolve or there's a marked improvement in the symptoms, then we know that FODMAPs is likely something that irritates the system. So what we don't know yet, though, is which FODMAP group or groups are the culprits. So that's where we go on to stage 2. We do a systematic re-challenge phase where each FODMAP group is reintroduced one at a time in a certain way, and that helps us to identify what the culprit actually is. And then we use that information for phase 3, which is the liberalization stage or the expansion stage, where that's essentially a person's long-term diet. So that's where some FODMAPs are limited to some degree and others are not limited at all because they can tolerate them. And that's the person's sort of longer-term diet. In saying that, though, they can always re-challenge the FODMAPs that are triggers for them, 6 months or so down the track to see if their tolerance has changed and see if they can bring back a little bit more. And it is the case for some people, it's not the case for others, unfortunately. But essentially, that's how the low FODMAP diet works with a 3-stage approach.
Oh, okay. I actually didn't realize it was so involved, to be honest with you.
It is, yeah.
I just sort of assumed that you lower the FODMAPs wait a few weeks to see if your symptoms clear up, and then slowly reintroduce. But I quite like the sound of your way a lot better, to be honest. Right. So okay. So we were talking about sort of low FODMAP and the sort of way you structure everything with patients, and that it's not just about reducing the low FODMAP. It's not just about reducing the FODMAPs to, say, a lower level, then waiting kind of 4 weeks or so. One of the other questions I've got, which actually I probably should have asked earlier in the session, was, how do patients sort of treat IBS on their own? Have you had people coming in and saying, I've tried X, Y, or Z, and it hasn't worked? Are there any sort of common things that people try and maybe they do work, or maybe they don't so much?
Yeah. Again, quite a mixed bag of people who I do see. So some people are newly diagnosed, and so they haven't tried anything. And so they come to me and we start from scratch. And then there are other people who have been trying to manage their IBS for quite a number of years, and they've had perhaps some success, but obviously not full success in managing their symptoms. Part of that might also be, though, because there are a number of strategies that can be used to manage IBS, not just what they've tried, not just diet. There are actually other things that quite often need to be used altogether for an individual's own personal toolkit for their IBS management. But when I'm sort of thinking about your question more specifically, some examples of what people have tried would be things like removing certain foods. They've tried probiotics. They've tried laxatives. They've tried herbal remedies, that sort of thing. They're probably the most common. I guess they do other simple things like using a heat pack or taking some Panadol and so forth when they need to. But they're probably the main things that people will come to me and tell me that they've tried so far and haven't had too much success with as a whole. Yeah.
Mm-hmm. And what was that last one? Sort of like painkillers, did you say? Something like over?
Yeah. If they have some stomach pain, some people might try some painkillers or some antispasmodics over the counter to see if they can settle down their gut that way. Might be partially successful, or it might have no effect at all, and so they're looking for other ways to try and settle down their symptoms.
Mm-hmm. One question actually that's literally just occurred to me, and I don't know whether you've found this with people. So have some people said that kind of skipping meals helps, like fasting helps at all? So if they have, say they have dinner on, I don't know, say a Sunday evening, they have dinner, and then they skip breakfast and lunch on a Monday, but then have dinner on Monday evening. That sort of time period, are people reported that to be effective at all in managing the sort of pain, I suppose? Have you seen that?
Yeah, I have actually. That's a really good point to bring up. So it's actually one of the strategies that some people do use to avoid their symptoms, particularly if they know that they've got something on. However, for them personally, it's not a long-term strategy that's sustainable, and it does obviously at some times displace healthier food options as well. We do know that intermittent fasting is used in for certain other conditions and so forth at times. But for IBS, I find that the vast majority of people do actually they do better when they have smaller, more frequent meals when they're not having their triggers, though. If you're having smaller, more frequent meals and you're constantly consuming your triggers, you're going to be triggering your symptoms. But if you're avoiding the things or limiting the things that you know will find out that trigger your symptoms, then they're much better off. But I do find that people use it as a coping strategy, but not usually a long-term strategy.
Yeah, I mean, I used to use it as a coping strategy.
Did you?
Yeah. A number of years ago, I would. I don't really eat pizza anymore, but pizza was my favorite food, so I would if I knew I was going to have it on a Saturday and it was, say, sort of a Thursday evening, I would avoid eating for a lot of the Friday. And yeah, it's a bad idea. But
Okay.
since I'm in Japan now, the chances of me getting a really good pizza are sort of slim, to be honest, especially where I am. So, okay. So one of the other things that I wanted to ask you, just to sort of go off on a bit of a tangent, is so I would guess that some of the patients you see, they manage to, correct me if I'm wrong, recover from IBS, and then some people don't manage to recover. Maybe they sort of just manage to kind of control the symptoms. In a very kind of general perspective, is there any difference between those two types of patients? Is there a sort of difference in maybe their emotional state, their outlook on life? Maybe some people just aren't willing to change their diet.
Yeah. So as far as we're aware, IBS, there is no cure per se for IBS, but there are some really good management strategies. So unfortunately, for someone whose IBS symptoms may resolve, there is a chance that they may flare up again at some stage in the future, for reasons that we don't know, or for other reasons such as environmental reasons. But we do find that the people who have much better management of their symptoms long term are those who are not just looking at diet, but are looking at a number of other factors as well. So things like getting enough sleep, managing their stress, because we know that the brain and the gut are very much linked, and they talk to each other both ways, brain to the gut, gut to the brain. And so if you're feeling quite stressed, it will make your gut more sensitive and more overreactive, and therefore you get more symptoms. We find that people who do more frequent, exercise, so basically lifestyle has a big part in making sure that someone's IBS symptoms are at bay for a longer period of time. And some people do actually need some sort of supplement or medication long-term to keep their symptoms under control as well. And obviously the diet part of it too. So if they do know that there are some triggers that they're sensitive to, keeping them below their personal threshold. So the threshold is the amount that they know that they can tolerate. For the most part, that helps to keep their symptoms at bay more consistently for a longer period of time as well.
Okay. So it's not about it's not about completely recovering, but about the extent to which patients manage to successfully control their symptoms.
That's right. Yeah.
Okay.
And that symptom management might be perfect. It feels like we don't have IBS anymore. I have had some patients who, they've limited their triggers, and they think, oh, yeah, I'm probably good with wheat fructans, and they try it again. Oh no, I still have IBS. Yep. That's definitely a strategy that works for me. But yeah, so it is about more really good symptom control. Some people might have some minor symptoms, and they can live with that if that means they can have a little bit of something that they don't really want to limit that much. So it's really down to that person, that individual, and how much they want to control their symptoms, because of the impact that this condition has on their quality of life and the things that they want to get done in their time.
Okay. Well, one of the things I wanted to ask you actually is there any questions that I'm missing? In other words, is there something about IBS that I haven't actually touched on that you think is important and that people should know?
Probably one of the biggest things is, again, it's kind of a mixed bag, but I think it's becoming much more well-known these days. But, you know, certainly, say 10 or so years ago, diet was not linked with IBS all that much. And so stress or depression or anxiety, that sort of thing, was sort of diagnosed, or the doctors were suggesting to manage mental health solely as a way of managing their IBS. So I guess to answer your question, I would really like to make it well known that diet can have a really significant impact on managing IBS symptoms. And for some people, it might be quite easy to figure out what their triggers are, but others, it can be a little bit more complex. And so don't wait, because when you do go on whatever type of elimination diet you need to do, whether that be low FODMAP or whether that be a reduced food chemical diet or some sort of combination thing that's going on, the symptoms can resolve quite quickly. So with FODMAPs, for example, FODMAPs only trigger symptoms as long as they're in the system, and that is, 2 or 3 days. And so after a few days on being on elimination, you can actually start to feel better if that is actually what's causing your symptoms or triggering your symptoms. Food chemicals can take a little bit longer. It can take a couple of weeks or a number of weeks, but you should certainly start to see a difference within 4 weeks. So essentially what I'm trying to say is, if you do have IBS, if diet is related, get onto it straight away, because you don't have to live like that and you can resolve it quite quickly.
Okay, that's great. What we'll do, we're coming up to time, so we'll wrap things up. Can you let people know where they can find you, whether that's sort of website, social media, or so on?
Yeah, so my website is www.thegutfriendlydietitian.com.au, and because I'm in Australia, dietitian is spelled DIETITIAN, not the C. That's the American way of spelling dietitian, which is quite confusing. I'm also on Facebook and Instagram, if you just search The Gut Friendly Dietitian as well.
Okay, that's great. In which case, I appreciate you coming on. That was fun. I enjoyed that.
Thanks so much for having me.
Thank you.